for 3 seconds and then start
Okay.
speech.
Okay.
You can type now.
Hello, good afternoon, everybody. On behalf of Hetero Healthcare, I, Dr. Prashant Kandebarkar, welcome you to this webinar on troubleshooting PCOS. Doctors, as you know, at Hetero, we market products in multiple therapy areas like in gynecology, dermatology, orthopedics, pulmonology, etc. With a very strong R&D support, we have developed many unique formulations keeping patient benefit in mind. Our endeavor is to develop products, formulations, or combinations which will improve patient compliance and ultimately the clinical outcome. We have developed NSAID patches, rivastigmine patches for better patient compliance. At Frenza, gynecology, obstetrics, and IVF is an important therapy segment for us. We market products for vaginal health like Feminora, Pellitra, etc. We have formulated and introduced vaginal film containing lactic acid. Amongst oral formulations, besides Dihydropal and other products, we market Mylotin, which is a unique nutraceutical for PCOS management. Mylotin contains myoinositol and dichloroinositol in a ratio of 40:1, chromium picolinate and melatonin, along with folic acid and vitamin D. To speak more about PCOS and management with nutraceuticals, we have Dr. Padmini Prasad with us. Dr. Padmini Prasad is MD DABS, practicing since 1978. Madam has more than 45 years of experience, is associated with Ramamani Nursing Home. Madam has written many books, newspaper articles, magazine articles on sexual and reproductive health problems. Dr. Padmini has participated and conducted programs. She has been honored by state government and organizations and institutes. Madam is awarded Kannada Sahitya Parishad Kempegowda Award, Karnataka Rajotsava Award, Golden Lamp and Silver Lamp Award. Madam, over to you. Welcome once again. We are waiting for your presentation. Thank you so much.
Thank you very much for that kind introduction. Namaste. Good afternoon to you all. And it is my pleasure to be a part of this knowledge sharing and knowledge exchanging, and also learning more about a very common problem. And I have probably a nightmarish problem for the gynecology. For this, I thank Hetero Healthcare for giving me this opportunity to be with you all to discuss about a very important problem any gynecologist will be facing. So day in and day out, you will be seeing PCOD cases. Just a minute, I will share screen, then continue with my talk. Okay. So this troubleshooting in PCOS. PCOS, as you all know, as I was telling, a nightmarish thing for any gynecologist. An adolescent comes to you with an irregular period, you look into the matter and she is having PCOS. An obese girl comes or an obese woman comes to you with more of her unwanted hair growth in the face and other regions, and then you investigate, she is suffering from PCOS. And the infertile woman, when she comes to you, most of them, or more than 50% of them, are suffering from PCOS. So any irregular period, weight gain, and excess androgen signs, and also infertility. So in most of the cases, when you really investigate, you are seeing more and more cases of PCOS these days. And when I was a medical student, we used to have only one case. For that case, we used to just run to all the people, and then just all the students used to run and see one case on Steen-Leventhal syndrome, what we used to call, just to study. And now I can see the change, how the incidence has changed. and how the incidence has increased over the years because of the changes in the society, the lifestyle, the diet, and then various environment pollutants, and so many reasons for having more and more cases of PCOD, which is creating havoc in a woman's body, right from the adolescent to the old age, and even leading to metabolic disorders, having a long-term effect, and also causing a intergenerational problem, passing on from one generation to the other, mother to the daughter, and then daughter to the next generation. So that is how we are looking at the problem of PCOD. So what we can do, there are so many varieties of symptoms as a syndrome, what we are seeing. So whether we have anything with us to treat such patients where a simple medicine can look into or take care of many symptoms which are there in the PCOS or the syndrome, what we call it. So whether we have anything, what are the things that we have, what are our problems, and is there anybody who is giving a proper medication which we can use and help our patients. So let us look into what is this PCOS and what can we do, what are the treatments that are available for us. The PCOS, it's a complex disease, so any gynecologist knows about it. 50 to 70% have hirsutism, 50% of women are diagnosed even with a thin PCOD, 5 to 10% of women of reproductive age have PCOS, 30 to 75% are obese or overweight, and 50 to 70% have insulin resistance. Every 1 in 5 women in India suffers from PCOS. That's what I was telling, how the incidence has increased and it has come to this stage. Polycystic ovarian syndrome. So one of the most prevalent endocrine system conditions.
Prashant sir, are you in touch with her or? Prashant sir, are you there? Priya Chauhan? You're on mute. Yeah, Priya.
I can, yes, I'm there. Doctor is logged out or what? I will just talk to a doctor. 1 minute. Huh?
Yeah, I think the internet is the issue.
Yeah, doctor is logging back again. Huh?
Okay.
Yes, sir. We are waiting for it.
Okay.
I just spoke to her. She said she's just joining.
Okay.
There's
Okay.
a disconnect in her net. Now she's logging again.
Okay.
Okay, can you see and hear me?
Yes, doctor.
Okay, sorry, I don't know what.
You can start from the beginning, doctor.
Okay, I will start from the beginning. So I was just talking to you. Anyway, I thank Hetero Healthcare for giving me this opportunity for of this knowledge sharing to know more about polycystic ovarian syndrome, which is a very common thing and which is a nightmarish experience of any gynecologist. Any girl who comes to you with an irregular period, or any obese girl or the obese woman comes to you and with irregular periods, you are diagnosing PCOS. And infertile patient, more than 50% of the infertile patients suffering from PCOS. And so all these things, irregular periods, obesity, and the signs of unwanted hair growth or the hirsutism. So you are going to diagnose this PCOS. Why this is the incidence has increased? What is the reason for that? So various changes, I think, I don't know whether you could hear me. So when I was a student, there used to be only 1 or 2 cases of what we used to call it as Steen-Leventhal syndrome. And so all the medical students used to run to that girl or the lady just to see what are the symptoms, signs, and that used to be a very big thing or a rare thing for us. But over the years, how the incidence has increased. And we are seeing every 1 in 5 girls or the women or the majority of the infertile patients or the irregular periods patients, we are seeing the syndrome of PCOS or polycystic ovarian syndrome. So because this may be because of various changes in the society in the form of changes in the diet, environmental pollutants, and also the lack of exercise, the stress, and various reasons which are leading to polycystic ovarian syndrome. So what it is, polycystic ovarian syndrome, it is a complex disease where there are 50 to 70% have hirsutism, 50% women are diagnosed thin thin PCOS, 5 to 10% of women of reproductive age group, 30 to 75% are obese or overweight, and 50 to 70% have insulin resistance. So every 1 in 5 women in India suffers from PCOS. The polycystic ovarian syndrome, it is one of the most prevalent endocrine system conditions affecting women of reproductive age, also known as hyperandrogenic anovulation or Steen-Leventhal syndrome. So it is a condition where at least one ovary has an ovarian volume greater than 10 millimeters with multiple cysts ranging from 2 to 9 millimeters. It is usually only diagnosed when complications develop that significantly reduce a patient's quality of life, hair loss, alopecia, acne, and infertility-related problems. This is the Steen-Leventhal disease, which I was describing. In 1935, it was discovered that a girl having hyperandrogenism, menstrual irregularity, and polycystic ovaries. So that time scanning also wasn't there. We used to so many times diagnose it during laparotomy only, that they had their polycystic ovaries were there. So that was the situation earlier. And the symptoms of PCOS, when you look into the reproductive problems, irregular menstrual cycles, hirsutism, infertility, and pregnancy-related complications, and metabolic features like insulin resistance, diabetes mellitus, and CVS complications. And psychologically, the girl or the woman would suffer from anxiety, depression, mood swings, reduced quality of life, and poor self-esteem. Pathophysiology of PCOS, there is a high consumption of carbohydrates, hyperinsulinemia, hyperandrogenemia, persistent low-grade inflammation. So these environmental toxins, genetic predisposition, gut dysbiosis, and all these things can lead to hormonal imbalance, hyperandrogenism, or insulin resistance, leading to the features of PCOS, and with the clinical features of hirsutism acne, reproductive features of oligoanovulation, irregular menstrual cycle, and subfertility, and metabolic features of the increased risk of metabolic disorders. So the diagnostic criteria of PCOS, there are varieties which have been described, like hyperandrogenism, whether there is ovulation, ovarian morphology, and exclusion of endocrinopathies needed for diagnosing, and number of criteria needed. So 1990 NIH criteria was there. There is a revised Rotterdam classification where there is a clinical or biochemical signs of hyperandrogenism, oligoovulation or anovulation, and polycystic ovarian morphology. With the exclusion of other endocrinopathies, at least 2 of the 3 criteria is there, then we call it as PCOS. So androgen excess or PCOS criteria, another clinical and biochemical signs of hyperandrogenism, oligo or anovulation, polycystic ovarian morphology. In this criteria, 1 plus A plus 1 of either criteria B or C, together with exclusion of other endocrinopathies. So majority of them take into account this hyperandrogenism, the menstrual irregularity, and the polycystic PCOD signs. So the clinical hyperandrogenism, there will be clinical evidence of hyperandrogenism. It includes hirsutism, acne, and 1 minute. Okay. So hirsutism, acne, and androgenic alopecia, all of which relate to the effect of androgens on the pilosebaceous unit. Hirsutism is the growth of terminal thick coarse hairs on the face or body in a male pattern. It is the most obvious clinical indicator of androgen excess and is an important feature of PCOS. So if you come to acne, the prevalence of acne is 12 to 14% among white women with PCOS. We are seeing more and more cases. The whole face is full of acne with so many scars, and the girl, when she comes in the adolescent age group, coming with so much of low self-esteem and the depression because of this, and not so many times they will get referral from dermatologists. So when they go to skin specialists for the treatment of acne, and then they refer them back, have to just go to gynecologist, have a detailed examination. That is how we diagnose PCOD in them. Higher in Asian Indians and women of Mediterranean descent. Alopecia, or the androgenic alopecia, or the loss of hair, describing scalp hair loss in women, also can result from hyperandrogenism and is a recognized but uncommon feature of PCOS. Less than 5% of women with PCOS complain of hair loss. But I have seen many girls with PCOS complaining of so much of hair is coming out. I am scared that I am going to become bald. So I have seen quite a number of cases of alopecia in PCOS. Typically, the hair loss is limited to the crown and does not involve the frontal hairline. Ovulatory and menstrual dysfunction. The normal intermenstrual interval ranges between 21 and 35 days, as you all know, and menses that occur less or more often are an indication of ovulatory dysfunction. The majority of women with PCOS, approximately 60 to 85%, exhibit gross menstrual dysfunction. The most common abnormalities are oligomenorrhea and amenorrhea. PCOS takes its name from the enlarged polycystic ovaries so commonly observed in women with hyperandrogenic chronic anovulation. Polycystic ovaries typically exhibit increased size and stromal volume and an increased number of small follicles. The Rotterdam criteria consider only the total number of follicles requiring 12 or more, measuring 2 to 9 millimeter in diameter. The prevalence of polycystic ovaries is quite high among women with androgen excess, that is more than 80%. However, from 8 to 25% of normal women and even 14% of women using oral contraceptives also meet the ultrasonographic criteria for polycystic ovaries. Moreover, polycystic ovaries are commonly observed during normal pubertal development and even in women with hypothalamic amenorrhea and hyperprolactinemia. So as soon as you see with scanning diagnosis, because so many times the girls come to you with taking one, they just go to the scanning center and then get one scan done and then go to the net, and then they have made the research and they just come and tell you that I am suffering from PCOD. In fact, it may not be in the early stages, in the early pubertal development, and some of the cases, just the presence of some cysts in the ovaries, it does not fit into the criteria of polycystic ovarian syndrome, but this is what is happening to us when we see our patients. The 2003 Rotterdam Diagnostic criteria expanded the population of women that might be assigned a diagnosis of PCOS by approximately 50% compared to the criteria earlier recommended by the NICHD, due entirely to the inclusion of polycystic ovaries. Abnormal gonadotropin secretion, increased serum LH concentrations, low normal FSH levels, and increased LH-FSH ratios are typical, but more so in lean than in obese women with PCOS. In the past, an increased LH-FSH ratio, that is more than 2:1, has been regarded as a marker of PCOS, but the ratio varies with the assays used to measure gonadotropin concentrations. Consequently, gonadotropin levels or ratios are not a reliable diagnostic criterion. They neither make nor exclude the diagnosis. In presence of insulin resistance, the overall prevalence of insulin resistance among women with PCOS is between 50 and 75% and greater in obese than in lean women with PCOS. Most women with PCOS and insulin resistance are young and have ample pancreatic B cell reserve. Consequently, they are able to generate a compensatory hyperinsulinemia whenever there is insulin resistance. So the glucose is not being utilized. So more and more insulin starts getting secreted from the pancreas, allowing them to maintain normal glucose homeostasis, at least in the fasting state. Dyslipidemia. This is also another common feature. It's most common metabolic abnormality observed in women with PCOS. Nearly 70% have at least one borderline or elevated lipid levels. Insulin resistance and hyperinsulinemia are associated with decreased HDL cholesterol and elevated triglyceride levels. Some also have observed elevated LDL concentrations. So how do you evaluate? If a woman evaluation of women with suspected polycystic ovarian syndrome, it should include serum thyroid stimulating hormone because it is an exclusion of other endocrinopathies also. So it is important to do a TSH level, serum prolactin, 2-hour oral glucose tolerance test, fasting lipid profile, endometrial sampling in women whose history indicates potential long-term exposure to unopposed estrogen stimulation, because there can be endometrial hyperplasia, or if there is some other form of hyperplasia, it may be important to diagnose that. Serum testosterone in women with moderate or severe hirsutism. Morning follicular phase serum 17-hydroxyprogesterone in women with a pre or perimenarchal onset of hirsutism, because there can be the other reason for hirsutism. So that also has to be, especially in the pubertal girl, a family history of congenital adrenal hyperplasia or high risk ethnicity. Overnight dexamethasone suppression test in women with signs or symptoms of hypercortisolism. So that is other endocrine disturbance have to be ruled out. Infertility, which is the major thing that we all worry about, that is the infertility affects 40% women with PCOS. PCOS is most common cause of anovulatory infertility Approximately 90 to 95% of anovulatory women presenting to infertility clinic have PCOS. In addition, spontaneous abortion occurs more frequently in PCOS with incidence ranging from 42 to 73%. Inherent ovarian disorder studies show reduced rate of conception despite therapy with clomiphene. So the quality of egg is also becomes important. So what investigations you can do when a girl or the lady comes with PCOD? The serum testosterone levels and serum DHEAS levels, 17-hydroxyprogesterone levels, serum TSH, prolactin, FSH and LH, total estrogen level, SHBG levels, lipid profile, AMH levels, and to know the reserve. So many times, I don't know, this wondering, it may be experience of other gynecologists also. We will be seeing the polycystic ovaries, and when you look into the AMH will be very low. Because usually in PCOD, we expect a very high level of AMH, but I am also seeing the reverse thing. TVS, it's a necklace pattern of follicular arrangement, and so 2-hour OGTT also is important. So when you get a case of PCOD, what are the goals of treatment? Because you have these varied symptoms, varied type of presentations, but all clubbed into one group of disease. So how to tackle the different symptoms, different signs, and how to give relief to the woman or the girl. So we are interested in regulating the cycle, improving insulin sensitivity, reduction of weight, improve fertility or the conception or the take-home baby, decrease androgens. So all these things are important. Whether we have any medication, which can look into all these symptoms or tackle all the symptoms. So management of PCOS is a condition that spans the lives of women, and it may represent even the fetal programming may represent the beginning of a syndrome characterized by all this H and I, or that's insulin resistance, which can have a series of medical consequences in adolescence, adulthood, and also old age. Menstrual and fertility problems evolve into metabolic complications as age advances, with early diagnosis being crucial if the aforementioned sometimes fatal complications are to be avoided. A precise diagnosis is important, especially at the extreme ends of the reproductive lifespan. Lifestyle therapy tends to be the first step in PCOS management, especially when excess body weight is associated. Pharmacotherapy is frequently used to manage the most predominant manifestations in each age group, such as irregular menses, hirsutism in adolescence, fertility problems in adulthood, and metabolic problems and risk of cancer in old age. Lifestyle, how you can improve the outcome. First line therapy is the lifestyle management for the fertility, reproductive, and metabolic. So a healthy lifestyle with the proper diet, regular physical activity, and reducing the weight for excess weight gain. So prevention is important for all women with PCOS, regardless of weight. Excess weight or overweight, aim is to reduce 5 to 10% weight loss over a period of 6 months. No crash dieting, because these days there's so many people advising so many types of crash dieting, and ultimately getting into trouble with their body, reducing the immunity, and all the problems our women are facing. So diet, there is no specific diet. So generally what with the energy deficit of 30%. So the weight gaining thing like sweets, fried things, and the rice, the carbohydrates, if they reduce that much, and with having more of vegetables and certain fruits, and more of curries and or bhajis, whatever we call it. So with that, if they have a proper diet, so that can improve their, that can lead to weight reduction, along with a proper exercise, or even at least a walk for 30 minutes every day. Exercise is the prevention of weight gain. It's of the moderate intensity, at least more than 150 minutes per week, or vigorous 75 minutes per week. So weight loss can be moderate intensity and with a very, so initially, as soon as we say you lose weight or do the, so without any causing the woman a conscious, she should not become very conscious of her weight, because we'll be creating more of a low self-esteem and poor self-esteem in the girl or the woman. So you can explain to them the advantages, do this, and then at least some amount encourage them, and then give them the proper diet plan and what the plate should have and what all things they can have. So all these things in a proper way, if you explain to them, they also will follow it. Don't feel bad, because as such, they're suffering from so much of body image problems and loss of self-esteem. So when you come to pharmacotherapy, low androgen oral contraceptives that contain drospirenone or progestin only pills, known as mini pills. So this can to regularize the cycles when the conception or the fertility is not an issue. An inositol supplement, which has a myoinositol, dichloroinositol, or a combination of the two, which can help manage PCOS symptoms such as hirsutism, acne, difficulty conceiving, etc. Metformin, you all know about it, lipid-lowering agents for women with lipid abnormalities. So what is the current gap in PCOS treatment? We have so many things, still we have a gap, and where certain things cannot be, a single drug is not taking care of all the problems. In lean PCOS, only for correction of PCOS we need. In infertility with PCOS, we need correction of PCOS and ovulation. In obese PCOS, we need correction of PCOS and weight loss becomes the prominent thing. And in there is insulin resistance, correction of PCOS, and insulin sensitivity has to be improved. And hormonal imbalance with the correction of PCOS and hormonal cycle. So there are varieties of things that we have to look into and then do the correction. So none of the formulations are giving the complete treatment for all these things. So addressing the gap, we have these active ingredients, myoinositol or dichloroinositol in the ratio of 40:1, which has got the benefits of regularizing the menses, improving egg quality, and restoring ovulation. Chromium picolinate, this improves insulin sensitivity. Melatonin, it also improves oocyte quality and also acts as an antioxidant. Vitamin D3, it improves ovulation. Folic acid, that also improves oocyte quality. So when the ideal therapy, which can improve all these things, so that is the one which can help us to treat our women. The myoinositol and dichloroinositol, that's more and more studies are coming up, and so that so the metformin, lot of studies have been done, but still metformin alone is not able to take care of all the symptoms of PCOD, and some of the ladies do not tolerate it also, and they have got some side effects, and they are not able to take the medication. So we have got this to improve the insulin resistance, to help the sugar metabolism within the cells. We have all these things, and many studies are coming up and many formulations are coming up. Even with many of you may be having your personal experiences also when you have used such combinations. So in PCOS, study shows a 500-fold decrease in the myoinositol levels of the ovary. So ovary, they have studied a decreased level, which is also needed to improve the insulin resistance. The follicular development is impaired owing to the reduced MI levels in the ovaries. Combined dose of MI and DCI is administered, which is found to be extremely beneficial in treatment of PCOS. Myoinositol has a substantial role in ovulation, while dichloroinositol has a role in insulin resistance, which can improve insulin sensitivity. So there is a medical rationale to administer them together. Thereby, the combined administration of MI and DCI in physiological plasma ratio, that is 40:1, is considered as the first-line approach in PCOS patients. Recommended myoinositol dose is 2000 milligram BID. So these are all the studies, the management of women with PCOS using myoinositol and folic acid. new clinical data and review of the literature. So it is an insulin sensitizer, and the moderate to severe side effects, no moderate to severe side effects were observed when this combination was used in the dosage of 4,000 milligram per day. In addition, the evidence suggests that a myo-inositol therapy in women with PCOS results in better fertilization rates and a clear trend to a better embryo quality. Benefits of MI-DCI ratio 40:1. So their myo-inositol and D-chiro-inositol are two stereoisomers of inositol and insulin sensitizers. In the human ovary, MI is a second messenger of follicle stimulating hormone, and MI mediates FSH signaling. DCI is an aromatase inhibitor. So thus, the combination myo-inositol and D-chiro-inositol ratio 40:1 will allow a treatment for PCOS. This ratio was able to improve the regularity of the menstrual cycle, acne score, the endocrine and metabolic parameters, and insulin resistance. This is another drug which is there, chromium picolinate. This is when chromium is combined with picolinate in order to increase gut absorption. When given in PCOS, it reduces hyperinsulinemia and hyperandrogenism. It acts by enhancing insulin signaling. It improves insulin sensitivity and facilitates fat loss. It is better tolerated than metformin. The combined action of both inositol and chromium picolinate on insulin regulation will help treat the underlying cause of PCOS. So this is chromium picolinate versus metformin, a study which has been conducted. The metformin versus chromium picolinate in clomiphene citrate resistant patients with PCOS, a double-blind randomized clinical trial. And this shows that this decreased FPS and insulin levels and increased insulin sensitivity in clomiphene citrate resistant PCOS women. So this is a chromium picolinate was better tolerated compared to metformin. That is the outcome of this result. And similarly, we have got many more studies conducted on this. Chromium picolinate was better tolerated than metformin due to lower side effects. Nevertheless, no significant differences were observed between the two groups regarding ovulation and pregnancy rates. Therefore, metformin could be replaced by chromium in some PCOS patients, as I was telling you. So some of them do not tolerate metformin. Is melatonin needed? That is another question which is there in the combination. Concentration of melatonin in pre-ovulatory follicular fluid is lower in women with PCOS. Melatonin supports nuclear maturation of oocytes in vitro. Even melatonin administration may be useful in vitro fertilization strategy and improve clinical outcomes of PCOS. Therefore, melatonin may provide improvement of oocyte quality and increasing pregnancy rates. It is also a sleep-inducing hormone, so it lowers stress levels. So this is how the melatonin acts and what are the advantageous aspects of melatonin. So melatonin, these are various trials are conducted, and the role of melatonin in PCOD, and this in the conclusion, since metabolic dysfunction is the major finding contributing to the initiation of PCOS, melatonin can hinder this process via its improving effects on metabolic functions. So another study trial which has been conducted, which is also showing the similar results. So it is effective to reduce the microscopic symptoms of PCOD related infertility. So another trial, melatonin in the clinical management of PCOD. So this is also showing a good result with the usage of melatonin. And apart from that, this what is the role of folic acid and vitamin D3 in PCOD? Folic acid help manage infertility rooted in ovulation problems for both women and without PCOS. Of course, folic acid we are giving regularly for all the women. It has got a role even in the treatment of PCOS. Vitamin D3 may play a key role in helping some women seeking treatment for PCOD related infertility, those who can get pregnant. So invariably, when we check the vitamin D, most of the women are deficient because majority do not go out in the sun, and the fear of tan, skin getting tanned. So these days we are seeing more and more cases of vitamin D deficiency. I think correction of that also is very important. So when you come to these various case studies, practically many of you might have used these combinations in different formulations which are available. So in such conditions, in my experience also, I have quite a few cases. I have tried this wherever the other things have not given a good result, and usage for at least minimum of 3 months or 3 to 6 months. And the correction of the clinical outcome we see in the form of correction of regularizing the cycles and irregular menses, heavy periods, and also the arrest, at least not increase of the hyperandrogenic symptoms like acne, hair fall, etc. And also getting pregnant. So this is how the correction of the menstrual irregularity and this reduction in the weight in the obese patients and giving them the pregnancy, the conception rate. So all these things I also have observed in my cases where I have used it for 3 to 6 months, and quite a few, even those difficult cases which I was thinking difficult to conceive. Even in such cases, I have seen good result with these combinations. I think it will definitely in the coming days when we use it, when we have more and more studies and more personal experiences and case studies, we should be able to know how we can use it or how we can improve these combinations and how well it can act. And this may be the experience of many gynecologists. And even recently also, when they passed on 3 months or 3 to 4 months I had used, and she has come back pregnant. And so this is one thing, because PCOD, as soon as they come to you, the first thing they ask, and I have got PCOD, everyone says I don't conceive, everyone says I will get diabetes, everyone says. So all these things they study, and they go to the net and study and come back with so many fears and anxieties. I think this should really help us. And we can have our own practical experiences when you use it in your practice. And then, so you also will be convinced. Once we are convinced and giving clinical results, see, whatever we study or whatever they say about the product, when it is your own personal experience and there is a clinical outcome in the form of good result and controlling the symptoms, ultimately leading to pregnancy, that is it. That is how we usually get confidence in a product. So then we can keep using, and everyone can, their own personal studies, their experiences, they can only draw the outcome and also become convinced. So this is all about how common it is and how the incidence is increasing, how we have got varied symptoms, and how it is, it will be, all the gynecologists will be happy if we can have the single, not using multiple drugs for one condition, and a single formula or the single drug medication, which can have all these things, which can control the different symptoms of PCOS. We all will be happy. And if you have your own experience, you can also discuss with us all these conditions, so that we can have your experience also. So thank you very much for the patient hearing, and people who are there, they can share their experiences also, and we will be happy. And so we can have more and more personal experiences with doctors. So I thank Hetero Healthcare for giving me this opportunity to discuss such an important topic, and also whether there is light at the end of the road, so that we can have a good preparation where we can use and help our patients. Thank you very much.
Thank you very much, madam, for this wonderful session. There's a few queries. You said you have been using this. Is there any specific type of PCS where you would prefer this formulation, like maybe metabolic PCS with more metabolic problems or more reproductive problems?
Yes.
Any such thing?
Those, see, where I have used is number one, when there is obese PCOS.
Obese PCOS.
And then infertility is the main problem.
Okay.
So this controlling the insulin resistance, and see, adolescent group, younger age group, we can use when there is the conception is not an issue. To control the cycles, the other forums start with the simple forums of lifestyle management, and OCPs can be used in such condition. But specifically when it comes to the difficult cases of infertility, very difficult, the hyperandrogenic states and irregular periods and infertile patients, these are the patients who really need some aggressive treatment. In
Correct.
such conditions, so when some of them really do not tolerate metformin also. So in such conditions,
Yeah, the adverse effects are too much sometimes.
so this we can have more and more, as you have more and more studies. I think with the correction or addition of some more nutraceuticals
That's right,
in
that's
the
right.
forum. So other things we can really improve the ovarian function and reduce the disturbance, and that should be fine.
Correct. Madam, each type of PCS age related. Each age has got something to do with type of PCS.
We are seeing right from the adolescent age, sometimes even delaying their menarche. That also we are seeing.
Okay.
So only thing is in the early stages, naturally for 2 to 3 years, till their system gets stabilized, they can have irregular periods, and
That's
some
right,
of them
that's right.
the hereditary obesity and such things can be there, but we have to be little careful
Right.
before making a diagnosis of PCOD. And even in normal people, sometimes just a scanning might show some multiple cysts and they may give it as PCOD without having any other complaint. So when we should make a proper diagnosis, and when it is used in a proper manner.
Correct.
Whenever there is signs of hyperandrogenism, most of them, if you rule out all the other causes of hyperandrogenism,
Correct.
so most of them will fall into this PCOS category.
A lot is spoken about this ratio of myo-inositol and dechiroinositol, 40:1. In your practical experience, does it make a lot of a difference in this specific ratio?
See, that is practically when you say that we use the drug and then see the result and the end, what is the end result and the outcome, because we really cannot go into the research. If someone has come with some other ratio and says, and clinically, if we see a good result, maybe we may think that.
I understand.
So you should have more studies in different ratios.
Yes, correct.
Studying various proportions, they have come down to this
40:1.
That
so
is
more
the physiological ratio in the body.
Correct.
So in the fluid, when you take it, there is a normal ratio of these two things, which is normally present in the body. And because that gets disturbed, and also the quantity of myo-inositol comes down, so that's why we have to replace it. It is another insulin sensitizer, where it will help the tissues or the cells to utilize the sugar, and the more and more of this sugar level.
This chromium, melatonin, apart from improving, reducing insulin resistance, they also have got anti-inflammatory effect, I suppose, which would further
antioxidant
help.
and
Anti-inflammatory effect.
Other forms of, because the harmful radicals are produced in any of these. So antioxidant can help in such conditions also.
Correct. These days they say gut dysbiosis could play a role in PCOS. Is it? What do you feel about it?
More studies are coming up. There is a disturbance and the changes in their diet pattern and the way they are eating and taking things. And earlier we had a particular type of cooking, and then type tested, and from our grannies and those
Yeah.
days.
Correct.
So they used to include everything, including probiotics and
Correct.
prebiotics and those. So that has been actually disturbed because of the newer type of change
Lifestyle.
in the diet and the lifestyle. I think that once you correct that, probably that also might help.
I mean, any adverse effect you've seen with this type of product on long-term use, 3-6 months?
Not
Not really.
specifically, I have not come up
Correct.
with such things.
I think that is all, madam. Once again, thank you very much for this wonderful insights. Thank you.
Thank you.
Moreover, I thank all the participating doctors who took time from their busy schedule and commitments and attended the webinar. Thank you, marketing team Hitro, for conceptualizing and organizing these sessions. As you all will agree with me, this type of session requires groundwork and coordination from field. And thank you, Hitro field personnel, for super coordination. Last but not the least, thank you, IT team Hitro, for your support and guidance in all technology-related matter. Thank you all once again, and wishing you a very pleasant evening. Signing off. Thank you.
Thank you very much. Thank you.